Hi, everyone. We're going to start before our final talk with Dr. Sivapalan. A family doctor by profession, Dr. Sivapalan believes in the potential for change to the current diagnostic landscape for children with autism. After 6 years of a busy and fruitful family practice, Dr. Sivapalan left his practice to help facilitate this change. With an interest in child development, he has worked collaboratively with multiple stakeholders to design the MDOC, a unique developmental screening initiative whose goal was to increase access to diagnosis and intervention support for newcomer communities. In addition, he helped develop the CARES initiative, which employed a task-shifting model to provide mental health support for caregivers and siblings of children with autism. As a social doer, he has initiated and managed various social impact projects, both at the local and global level. Most recently, Dr. Sivapalan became the Chief Operating Officer for the Dunya Project, a Canadian agri-tech startup that is building a connected, climate-controlled hydroponic habitat to alleviate the devastating gap in access to affordable foods, irrespective of climate conditions. Please welcome Dr. Sivapalan.
Wow, that sounded amazing. Can you send that to my wife, please? Okay, so good afternoon, everyone. You're probably expecting this to be one of the better presentations of the day. I want to say don't expect a lot. No high expectations. But anyway, so first I'd like to thank everyone for being here. It was a great day with a lot of great speakers, a lot of great information, a lot of good discussion about access. So my name is Sivapalan. As she mentioned, I'm a family doc by practice. I've been working with SAAAC for the last 10 years, first as a volunteer, then as a board member, and now more in project and program development. So today I'll be speaking to you about what we warmly term the MDOC, which is a Mobile Developmental Outreach Clinic that we started, well, the first iteration started in 2016. Okay, so before I first start, I just wanted to take some time and thank key people, key organizations, key stakeholders that have helped make this project possible. First and foremost, I want to thank Autism Speaks Canada for not only funding our pilot project, but believing in this vision of this project when we initially started it as a walk-in clinic model. Their support has been vital in getting us to the point, and with their continued support, we hope to further enhance this model. I'd also like to thank McMaster Autism Research Team, specifically Dr. Georgiadis, I hope I said that right, Nicole Kim and Anna Kata for helping with the evaluation component of this project. Also Thorncliffe Collaborative for Muslim families, Health Access Thorncliffe Park, and all the early on centers without which this project wouldn't be possible. Also, a special thanks to Dr. Zuberi, I don't see him in the audience, but for all his insight and guidance. Also Nishan Shanmulingam, my partner in crime, an ABA therapist by training and one of the co-developers of the MDOC. Safira Mula, our transitional caseworker, who is a key component in helping families along the path to diagnosis, and Kingston Yogendran, which many of you probably have heard of, who's essential in helping us establish our partnerships. From its creation, SAAAC has always believed in one thing, and that is making autism care equitable for all Canadians. And in the same light, one of our goals of this conference was to highlight novel approaches that helped improve access for underserved populations. So let me give you a scenario. It's a fairly common scenario. But imagine being a mother that just recently immigrated to Canada from Sri Lanka. English isn't your first language, right? You're living on a single income with your husband working long hours during the day to provide for your son and daughter. Then you notice that your son, who's about 2 years of age, is still not speaking, doesn't always respond to his name, and does not point to things that he wants. You remember back to when your older daughter was about his age, and don't remember her having the same difficulties. You start to question yourself and think, maybe it's your fault. Maybe it's because you didn't spend enough time with him. Maybe you let him watch too much TV. Now, the sad part is you have no family or friends in Canada, so you decide to call your parents. your parents live in Sri Lanka, and you tell them about your concerns, which they quickly dismiss. They tell you he's a boy. A boy tends to always speak late. Your mom even brings up a story of your brother who only started to speak at the age of 4. But something in your gut tells you that there's something more to this. And if there is, how will your husband react? Will he leave you? How will your parents react? How will the Sri Lankan community in Canada react? So it takes you months to build up the courage to want to get your son assessed. But when you're ready, you realize you're just as lost as you were when you first came to Canada. You don't know how the system works, you don't know where to go to or who to go to. So how does this mother get on the pathway to assessment and possible diagnosis? Now, the sad part is, this is a fairly common story. We hear this from all our families at SAAAC. Okay, so when we're looking at immigrant and newcomer families, data has shown that they receive a later diagnosis. This was highlighted by Dr. Zuberi's presentation earlier. Now, there's a multitude of factors that cause this, and it was highlighted in that scenario. Factors such as language barriers, adjustment to living in a new country, unemployment, lack of knowledge of the new country's systems, services, and supports. The big one is cultural perceptions of special needs, poverty, and fear of deportation. So as a result, children with autism from newcomer and low-income families typically face poor health, poor outcomes and quality of life. It's interesting to note that when CASDA did their 2014 National Needs Assessment Survey, they found that, or they recommended that there needed to be a targeted outreach to linguistically and culturally diverse communities to facilitate better understanding of their service needs and improving their access to services. So SAAAC has always prided itself as a treatment agency. But over the last few years, what was happening was we were getting a lot of families coming to the center looking for a diagnosis. At that point, because of lack of resources and personnel, we would just redirect them to their family doctor or pediatrician. The sad part was that most of these families would show up 6 to 8 months later, still without a diagnosis and wanting to get into services. So we asked them, why didn't you follow up with your doctors? And most of them would say, one was fear of a diagnosis, and mothers were specifically worried about their husband leaving them. Language barriers played a role, and societal implications also played a role. But the most common complaint was the wait time to see a specialist. So in Ontario, the average wait time for ASD assessment is about 31 weeks, and it can go up to 4 years in certain areas. There's currently about 2,400 children that are in line for an ASD assessment. And there's about 23,000 children that are on the wait list for post-diagnostic services. So what do we do? So currently, the most common pathway for families to go through is going through their family doctor. So they go through their family doctor. The family doctor will do a typical level 1 screen, which is what we call the nipping, or now it's newly named the look-sees, or an MCHAT based on the child's age. If the screen's positive, the child will be referred to a specialist, such as a developmental pediatrician, for further testing. Now, there's a few issues with the current model. One is we don't have enough specialists, and Mohammed won't let me clone him. Number two is that our level 1 screeners, one, may not be as predictive of autism as we might think. So let's look at the MCHAT, for example. It has a lower positive predictive value for ASD, which means you get a lot of false positives. So what ends up happening is if a child scores positive, family doc refers them, they get added to the wait list, and again, the wait times get longer. The other aspect, which is discussed in multiple presentations today, is how culturally sensitive are some of these screeners. The other aspect from a family doc standpoint is, can a family doctor effectively screen a child in a busy family practice setting with just above tools? I know personally, as a family doctor, that when a child's coming in, they're typically coming in for immunizations and a checkup. So they're already anxious. The minute they step into the waiting room, they're already like, oh my God, brown walls, I'm getting a needle today. They're very upset. Parents at that point typically are just anxious and want to get their child in and out as soon as possible. So we'll sometimes forget any concerns to bring up. The appointment gets rushed. The other aspect as a family doc is there's typically a gap between 18 months and 4 years where children will not be visiting their family doc unless there's a specific concern, because there's no immunizations from 18 months to 4 years. So a lot of times during that critical time period when you may see some of the signs of autism, these children aren't seeing anybody. So what did we do? So we decided in 2016, we wanted to figure out a more efficient way for screening and diagnosis. And we piloted what we called at that point the walking diagnostic clinic, which gave us a lot of great information and feedback and lessons. And then this eventually led to this Mobile Developmental Outreach Clinic, which also kind of coincided well with what was happening in Ontario, where there was a need for a better system that reduced wait lists, time to diagnosis, and access. So how this worked was, let's pull all this out. Okay. So this model employed a team of a behavioral therapist, a transitional caseworker, and a GP going out to various sites to administer an enhanced developmental screening for concerned families. We specifically targeted early on centers and schools because we wanted to target children between 18 months to 4 years of age. As you look at this, our qualified team, how it would work they would initially see us, they would have the screening done, and we focused on culturally responsive care in terms of how we did our screening. And I'll talk more about this later on. So what we were looking at, and if you look at this little, I guess, diagram, on your left side, you see the typical pathway, or what we call the non-MDOC pathway. And there's really only one typical point of access, right? You go through your family doc, and that starts the process. What we try to do with the MDOC pathway is to increase the number of access points. And by doing so, we would get more families from underserved populations. So access points now would be early on centers, community centers. The family doc obviously is still there. And what we didn't anticipate, but we found, was that word of mouth was also huge. Once parents had a good experience with the MDOC, they started to spread the word to other families. And some of our MDOC sites became central sites for other early on centers to refer, so became spokes for a central early on site. So with the MDOC pathway, our focus shifted from the diagnostic clinic where we were doing diagnosis, shifted towards triaging and screening, and an emphasis was made on accessibility and culturally responsive approaches. We focused on community engagement, creating awareness, and we also utilized community leaders to help establish culturally responsive practices. We targeted communities that were specifically limited, had limited access, that included newcomer families, families with language, cultural, and economic barriers. And like I mentioned, we focused on creating more than one access point and being mobile. So we go to them rather than them coming to us. And with the MDOC, what we really emphasized was this cultural nuances. So we tried to echo what Dr. Sarah Bauer had found in her autism-specific medical research, which was it is crucial to work closely with the child's own cultural community and stress the importance to work with people that understand intimately the expectations within the community for what autism means to them. And hence, we decided to approach community leaders to create these cultural liaisons, because we knew that different cultural practices and beliefs about child development may indirectly affect the age at which ASD is diagnosed. So for example, in some cultures, standard indicators of ASD may not elicit concern at an early age, such as eye contact, use of an index finger to point to share interest. So these are things that we wanted to look at more closely. And some families from diverse ethnic backgrounds may view different difficulties, such as communication difficulties or social skills difficulties, as temporary, as part of the normal developmental process. So this made it likely for these families to notice the subtle signs that you can see in early autism. But it was interesting to note, while we were doing the MTalk, and it kind of was backed by research, is that major milestones in language acquisition seem to be consistent across languages and communities. What most of the families were coming in to get screened for was language delays when they came to see us. And we also noticed another thing that kind of fit into the whole aspect of are these level 1 screeners culturally appropriate was when we were doing the walking clinic model, when these families were filling out these screeners in the waiting room, and then they came with us and we would go over it, and then we would either verbally translate it to a language that they're familiar with and go over each question, specifically go over what they were looking for. The two screeners looked completely different. It was like I'm seeing two different children if I just based it off the screeners. So we kept this in mind. We also kept in mind that immigrant mothers may also struggle to acknowledge the diagnosis of ASD in their younger kids in an attempt to preserve hope for their child's future and their possessions. So we use this to help formulate a plan. So our approach, and this is something that we've worked a couple of years on, was to balance the need to convey accurate medical attention to these family members at the same time by balancing the need to keep the parents invested in their child. And to do this, we needed to understand our own cultural bias, speak to them in their own language, needed to use cultural liaisons to continuously learn, and provided adequate time for parents and families to voice their concerns. That's why each one of our appointments was anywhere from 45 minutes to an hour. Most of the assessment was done probably in half an hour, but it was the extra half an hour that was very valuable for their parents to kind of express everything they wanted to, get all their questions answered. And the other thing that we constantly kept in the back of our head was that this is an evolving process, and we are constantly learning. So normally, before we would start any type of screening at any site, we would first do a presentation for all the families that attend the Early On Center. And we tailor-made these presentations for these families. So instead of multiple slides of checklists and going over all the different delays, we focused on typical versus atypical developmental health, and we used a lot of videos and images. And that seemed to connect more with families. The other thing we focused on is, just through our work at SAAAC and our experience, we anticipated some of the preconceived notions that they may have of having a child with autism in Ontario because of their experiences in their country of origin. So we addressed some of those concerns. We addressed the differences that they would have here versus, for example, Sri Lanka or India, where supports are not as easily accessible. So by doing so, we were able to create a non-stressful environment for parents to come and have their child screened. So first step was holding these culturally sensitive health presentations across various Toronto neighborhoods with support from our partner sites. After which, interested families would book an appointment to see us, and the child is assessed by both myself, a general practitioner or family doc, and an ABA therapist who would provide an observational assessment of the child. We still employed the typical level 1 screeners, and we also utilized a relatively new, some of you may have heard of it, a level 2 screener called the RITA. I'm going to go over the RITA. So the RITA is called the Rapid Interactive Test for Autism in Toddlers. It is typically a screening test for children under the age of 3, and it allows for better identification of toddlers with very high risk of ASD. And it was actually created by a developmental pediatrician out of the States, Dr. Rula Chueri. And it's an interactive play-based assessment that can be done anywhere between 5 to 10 minutes, and it focuses on the following domains: joint attention, social awareness, awareness of human agency, self-recognition, and fundamental cognitive skills. It's fairly reliable in 18 to 36 months. Scores, so how the RITA-T works is the child gets a score between 0 and 30. A score over 12 is considered positive. A score over 16 is considered high risk for autism. Also, at the bottom of the scoring list is a few additional observations, and if made, despite a low RITA score, you would still refer them off because there's a chance that you may be missing something. And some of these observations are hyperactivity, sensory-seeking behavior, difficulty getting attention, and so on. So if the screening revealed further testing, the child would be referred off to the developmental pediatrician. Now, the one important aspect about this model was that we followed the negative screens. So we did not assume that we were completely perfect and that I knew what I was doing, and all the children that I screened, screened negative did not have autism. So we followed them at 3, 6, and 12 months of age. And when I talk about the results, this was quite useful because there has been about 3 times where we have looked back and reassessed the child, and yes, the child ended up scoring positive, and then ended up later getting a diagnosis. Here's the other unique aspect about the MDOC program. We involved what we call a transitional caseworker, who played an essential role in helping families navigate through the pathway. So what we learned when we first did the walk-in clinic model was that after they got the diagnosis, they would just come back to us and meet with our case manager on site, and they would be directed towards services as needed. The problem was, what was happening was some families after the diagnosis would not come back to us and connect with us. And so we were losing them in follow-up. So what we decided to do with the MDOC was we got the transitional worker involved the minute the referral was made. So when I made a referral for a child to see a developmental pediatrician, within the first 1 to 2 weeks, our caseworker would call the family to see how they're doing, to see how they've handled the possibility that their child may have a developmental delay, and to see if there's any questions or anything that they wanted addressed at the visit, but they couldn't. And what we found was she was able to provide reassurance and ensure that they were taking the right steps towards going for the assessment, and then in the post-diagnostic phase, going for intervention. And feedback from families was that her presence was key in them following through with not just the assessment, but also following through for intervention. And they also found her extremely valuable in the post-diagnostic period where they were going through the grieving process, struggling with coming to acceptance. And with her help, because with her, she was there. She was holding their hand until they were ready to let go. So the transition worker would typically work with families until they were engaged with services or the hospital social worker or caseworker took over. Okay, so this is the good stuff. So with the help of MacArt, what we were able to do is we developed a goal-oriented evaluation plan prior to the implementation of this MDOC. And this was to kind of assess if, one, we were actually serving low-income and newcomer families, we were actually helping reduce wait times for ASD diagnosis and post-diagnostic services, and that we were actually delivering culturally sensitive practices. And how we did that is we compared it to our SAAAC business as usual or non-MDOC practices. So MDOC data was collected prospectively via intake forms and a post-MDOC survey and follow-up calls. The non-MDOC data, which is families that have gone through the typical pathway, were collected retrospectively through surveys for caregivers of children who've participated in that pathway. Okay, so over the last year, 175 patients were booked to see us over these 10 sites that we have. 124 showed up. And out of the 124, 108 consented for us to use their data to be evaluated. Now, one of the main reasons for the 51 that did not show was typically it would only take them a month to get an appointment, but in that month, most of them would say that the perception of their child was that their child was fine at this point. This kind of indicated a need that maybe our efforts weren't enough in supporting parents to becoming more comfortable with their concerns about their child's development. And the interesting part is, of the 51 families that no-showed, the majority of them were families that the early on staff were highly concerned about and felt they should be assessed. Now, out of the 108 that did consent to us analyzing their data, 58 were screened in and 50 were screened out. Of the 58 that were screened in, 42 were seen by the specialist, a developmental pediatrician, 37 were given a diagnosis, 5 were not given a diagnosis, and 3 that were screened out initially were screened in on follow-up visits. And then in comparison, we were able to get 56 families that went through the typical pathway to kind of compare. Okay, so this is what we were able to show. I'm actually going to go one slide forward. So these are the 10 sites that we initially worked with. We were working 2 days a week, typically, and we worked at each one of these sites. We would typically go to each site once a month. Some sites had significant volume, and we would sometimes have to go twice a month, but the majority of them was once a month. So what we were, again, trying to do with the MDOC is improve points of access. So with this, you can see the area we were able to cover and the neighborhoods that we were able to cover. Now, what we were able to determine through the MDOC was that community partnerships are essential and very influential in encouraging initially hesitant families to participate in the MDOC. And as you can tell by this, so these are the surveys that the parents would fill out, and one of the questions was, how did you hear about this clinic? And the majority, as you can tell, heard about it through the Early On Center and through their awareness campaign. In addition, what we were able to show was the average age of diagnosis for the MDOC pathway was 3 years and 2 days, versus when we compared it to those 56 families that went through the typical pathway, the average age of diagnosis was 5 years and 6 months. The average wait time from referral from the general practitioner to the developmental pediatrician with the MDOC pathway was 1.77 months. I'll go over it in more detail after. But through the non-MDOC pathway, only about 10% of the families were able to get in the first 1 to 2 months. The rest, the majority of them the rest of them had to wait at least 3 to 6 months, and in fact, a significant amount, 42 of them had to wait between 7 months and 7 months to over 2 years. Okay, so this is where we could highlight this. So when you look at the left side, you can see the typical pathway, and it typically takes, on average, 31 weeks, versus when you look at the MDOC pathway, it takes about 15 to 16 weeks, and the 15 to 16 weeks includes the presentation component of prepping a site as well. So that 3 to 4 weeks where we initially go in, prep the parents, give them the presentations, prep the early on staff, and so on like that. And then afterwards, then they book in to see us, and then we refer off. So that includes the entire MDOC pathway. Now, as you can see, just like what I highlighted before, of those 56 families, you can see how many actually were diagnosed within the first 1 to 2 months, 3 to 6, 7 to 1 year, 1 to 2 years, and more than 2 years. Okay, so the most common question I get asked is, why has there been a reduction in wait time? So what are the possible reasons? So one, we're reducing the number of unnecessary referrals to the specialist. The other aspect is, and this is feedback directly from the developmental pediatricians, is that the information transferred on the referral form helped reduce the amount of time that the specialist had to spend, or the diagnostic team had to spend with each child. The other aspect is that the children that underwent the RETA T testing, and with the scores, the specialists and the diagnostic teams were able to better triage families. And the triaging aspect itself helps reduce some of the wait time. And the final aspect, which kind of fits into point number 2, was the families that went through the MDOC, a lot of the developmental pediatricians felt were better or were more ready to start the treatment process and had gone through the grieving aspect quicker than what they'd seen in the non-MDOC pathway. And what they had found is they needed less time in terms of counseling and prepping families that had gone through the MDOC pathway. So we're not perfect. As I mentioned before, out of the 42 that were seen by the developmental pediatrician, 37 were diagnosed. 5 did not lead to a diagnosis. So we did a deeper dive into the 5 that didn't get a diagnosis. And what was interesting to note was 3 out of the 5 was a result of a combination of a low RETA T score and us checking off one of those observational checkboxes at the bottom, specifically the difficulty getting attention one. So it's something that we've been looking into to see is that something that we need to work with, or is that something that we need to have additional information for? And with the RETA T, great tool, but we ourselves have modified it slightly. When I say modified it, one aspect that we noticed is one of the tests on the RITA-T, and this is our ABA therapist that figured this out, involves placing or drawing a dot or placing a sticker on the child's forehead. And the child is looking into a mirror, and without any cues, you just observe how the child reacts to seeing himself or herself in the mirror, and what they do with the sticker or the dot. And what our ABA therapist had known after the first few months of us doing this, especially doing the walking clinic model, was the children of South Asian descent, specifically the girls, when the dot was placed on the forehead, didn't really care. Didn't notice anything, didn't say anything. But when you asked them, oh, do you see the dot, and so on, like you cued them, then they would point it out and they would tell you. So it's just because in certain, especially in Hindu culture, you place a dot a lot of times on the forehead, so they were just comfortable with it. It wasn't something new, it wasn't something abnormal for them. And so he made the suggestion, let's just move the dot to the side of the cheek, or and it was great, and it worked the same way. The minute we moved the dot over here, child noticed something different. So obviously there's things that we've learned, and another cultural aspect that we tried to incorporate. The other interesting part with our non-perfect model is there were also 2 referrals that we did score a low RITA-T, but we had one of those delayed signs, and that did get a diagnosis. So again, a little bit more research needs to be done on those little observational checklists and seeing which ones are more reflective of a child with ASD. So our culturally responsive approach, and this is something that we talked about earlier, so I'm going to kind of skim through this one. But what I wanted to focus on was this. And I'm going to show you a comparison. So hold on. Let's go back. OK, so we did a feedback survey for all the families that went through the MDOC, and they would typically do it right after their assessment, and it was anonymous. They could drop it off at any point. The interesting aspect is I was expecting a lot of the families, especially if we were telling them that there are concerns and that we were referring them off, this would directly affect how they would perceive that visit. But it didn't. It seems like they loved us, or at least they loved our ABA therapist. And this just shows it in a graph form. But we also did that with our non-MDOC families, just to show what their satisfaction level was during their process when they went through the typical pathway. And you can see the difference. A lot of them, there was definitely some satisfied parents, but you could see that quite a few, or quite high percentage of them, were dissatisfied with just the diagnostic process. And most of them, if you ask them specifically what about it, it's specifically the wait times. And most of them, there was also issues in terms of receiving services. And again, that was probably wait time. So what we've been able to do, and this is very high level, I haven't gone in too much depth over this, is the benefits of the MDOC. And one is the ability to create multiple access points that include early on centers, family docs, and parents. The mobile aspect, so going to the families rather than expecting the families to come to us. The cultural sensitivity aspect of us, the fact that we're constantly evolving, trying to cater towards our patients. The collaborative model, which is something that I find extremely useful. The fact that I have an ABA therapist with me, not only for the observational component and the RITA-T testing, but also right after, because when you're telling a parent that they're probably going to be referred off and there's concerns, parents will typically ask you questions. How do I deal with my child's tantrums? How do I deal with my child's escape behaviors? And it's great to have an ABA therapist on site that kind of just helps them navigate through some of those concerns. The use of our transitional worker, which I think is very key in ensuring that patients continue through the process and then don't drop out. We found that it's a more effective way of triaging cases, and then we have also shown that it reduces the number of false positives. The other aspect, which is, I wish there were some politicians in the, is a cost-saving aspect. So we looked at the benefits of the MDOC from a cost-saving analysis, and again, this is very high level, but we did just look at OHIP billings, and there was about a $45,000 savings for the 108 families that we're seeing, mainly for the families that were screened out because they wouldn't have to go to a developmental pediatrician. Obviously, there is a cost saving for early intervention, but that needs more research to figure out a number that's more usable in Ontario and specifically Toronto. And just looking at the graph on your left, what it showed was that a large number of these families that came through the MDOC were visiting healthcare professionals quite frequently over the last year. So when we asked them this question, the number of times they visited their healthcare facility in the past year, you can see the number. But we asked them what specifically made them go. And I was assuming it was colds, coughs, and so on like that. And no, it was typically behavior related or issues where they were worried their son or daughter was deaf, or because they weren't listening to them, they weren't following instructions. So the majority of them were behavioral related. So we would assume with the MDOC pathway that some of these visits would have been prevented. So what's the future of the MDOC? So obviously we've shown that we can reduce the wait time to diagnosis, but there's another wait time, and the wait time is post-diagnostic services. So what we're planning to do is incorporate parent-led interventions post-diagnosis, or in some cases, depending on the severity level, for children that are, I guess, higher risk of ASD, getting them enrolled in some sort of parent-led intervention that could go based on a provisional diagnosis. So programs such as social ABCs or pivotal response therapy. So what we want to do is incorporate that. The other aspect that we want to incorporate, and some of you may have heard, the SAAAC Cares program, which is a parent-based model that focuses on counseling families that have just received a new diagnosis, just to help with transitioning and helping them with workshops and resource navigation. The other thing that we want to include going forward is a video screener or a video library that could be utilized by family physicians, mainly because when we were trying to describe symptoms such as stimming, mouthing, finger movements, or hand flapping to a lot of families, they found it very difficult to understand. Versus when we showed them a YouTube video, they were like, yes, my son or daughter does that. And it clicked for them. So having something that's easily you can pull out and just show them, and that's visual, I think would help facilitate understanding from the parent standpoint. And the final aspect, which was something that the transitional caseworker brought up, was resource navigation. A lot of families, when they get the diagnosis, are given a sheet of paper and told to contact A, B, and C, and this is for funding, this is for services, and so on like that. And a lot of times, that paper either gets lost or they are overwhelmed. And most of them will actually call us and ask us what the next steps are. So what we're planning to do is help develop a navigation app that's location specific that could help with them in terms of accessing parent-specific resources, child-specific resources, and respite care and so on like that. We also plan on scaling the model. We're right now thinking of increasing the number of early on partner sites. Sick Kids was interested in us helping out with their community initiatives. We also want to scale the model to Hamilton and partnership with McMaster Children's Hospital. We've also had a lot of family physicians come to us and ask us, can we be trained? Can we do this? And that's our goal, is to get them trained so they can do this. It shouldn't just be me. And so this is where we were talking about the incorporation of that parent-led intervention and where it would be included. There is that other aspect for certain children, but right now we're thinking of just the post-diagnostic phase. All right, I hope I covered everything. Thank you. Any questions?
Thank you very much, that was great. In your costing analysis,
Yes.
Did that include the other staff, the non-medical personnel?
Yes.
Okay.
Yes.
Fantastic.
With the OIT billing, that number that we use was also including the cost for the transitional caseworker as well as the ABA therapist.
Beautiful.
Thank you, Dr. Sivapalan. This is the Goodness Gift Basket
Thank you.
that was made by the adults at SAAAC. For anyone interested, we do have flyers on how to order these outside. So thank you very much. Thank you.
Thank you.